The FDA approved this pill for two specific conditions. Doctors now prescribe it for dozens. Prescriptions increased by 170% in just 7 years. And a large study published in 2025 found that people taking it long-term for back pain had more than double the risk of developing dementia. Most people taking it for pain have never been told any of that. There is a medication that is everywhere. In pain clinics, in psychiatry offices, in primary care waiting rooms. Prescribed for nerve pain, for anxiety, for insomnia, for migraines, for restless legs, for back pain, for fibromyalgia, for post-surgical recovery. Its prescriptions increased by 170% between 2009 and 2016, and they have continued rising since. By 2018, it had become the sixth most prescribed medication in the entire United States. That medication is gabapentin, sold under the brand name Neurontin. And here is the first thing most people taking it do not know. The FDA approved gabapentin for two specific conditions: partial seizures and nerve pain from shingles, a condition called post-herpetic neuralgia. That is it. Two conditions. Everything else, every prescription for anxiety, for chronic back pain, for insomnia, for migraine, for the dozens of other conditions it is now routinely prescribed for, is off-label, meaning the FDA never reviewed evidence for those uses, meaning the prescriber is using clinical judgment in territory the regulator has not formally mapped. This is not inherently wrong. Off-label prescribing is legal and sometimes appropriate, but it means millions of people are taking a medication every day, often for years, for a condition it was never officially approved to treat. And that gap between what was studied and what is prescribed has consequences that are only beginning to be fully understood. To understand what gabapentin does and why the long-term picture is becoming more complicated, you need to understand how it works in the brain. The brain runs on electrical signals. Billions of nerve cells firing signals to each other. Every thought, every sensation, every movement produced by the precise coordination of those signals. Those signals need to be calibrated. Not too fast, not too loud, not too intense. When nerve signals fire too powerfully or too frequently, as happens in epilepsy or in certain types of nerve damage that produce chronic pain, the result is a nervous system that cannot turn itself down. The pain keeps coming. The seizures keep happening. The signal never quiets. Gabapentin works by blocking the entry of calcium into overactive nerve cells. Calcium is part of what allows a nerve cell to fire a signal. Block the calcium, and the cell fires less intensely, less nerve activity, less pain signal reaching the brain, less runaway electrical activity in epilepsy. For someone experiencing severe nerve pain after shingles, the kind of burning, electric, unrelenting pain that makes ordinary life impossible, that quieting is genuinely meaningful relief. But here is what that mechanism also does. The same calcium channels that gabapentin blocks in overactive pain nerves exist throughout the nervous system, in the brain regions that manage alertness and attention, in the memory systems of the hippocampus, in the circuits that support clear thinking and fast processing. When gabapentin quiets the pain signal, it also quiets other things. Not dramatically, not in a way that is immediately obvious, but measurably, in ways that the clinical trial data captured and that the FDA label reports directly. The FDA label for gabapentin lists the following cognitive side effects from clinical trials in exact percentages. Drowsiness, 19% of patients. Dizziness, 28% of patients. Memory problems, listed directly. Abnormal thinking, listed directly. These are not rare events recorded in isolated case reports. These are the rates from the controlled clinical trials used to approve the drug. More than 1 in 4 patients experiencing dizziness. Nearly 1 in 5 experiencing excessive drowsiness. For a medication taken by tens of millions of people, including more than half of prescriptions going to patients over 65, these numbers represent an enormous amount of daily impairment that goes unrecognized and unaddressed. If someone you know takes this medication and feels slower, foggier, less sharp than they used to, stay with this. Beyond the effects documented in clinical trials, research published in 2025 raised a concern that is still being actively discussed in medicine. A study following over 52,000 adults with chronic back pain over a 10-year period found that patients taking gabapentin long-term had a significantly higher risk of developing dementia and mild cognitive impairment compared to patients who did not take it. Patients who received 6 or more prescriptions had more than double the risk. Those who received 12 or more prescriptions had a 40% higher risk of dementia and a 65% higher risk of mild cognitive impairment compared to those who received fewer prescriptions. The researchers noted that the risk was particularly elevated in middle-aged adults, people between 35 and 49. This does not prove that gabapentin causes dementia. The study cannot establish causation, only association. But an association this strong, in a study this large, following patients for this long, is not something that can be quietly set aside, particularly when the FDA label already documents that gabapentin impairs cognitive function during use, and particularly when more than 50% of prescriptions go to patients over 65, the population already most vulnerable to cognitive decline. The FDA also issued a warning in 2019 about a risk that is less discussed but immediately dangerous: severe breathing difficulties when gabapentin is taken alongside opioids or in patients with existing respiratory conditions. Both gabapentin and opioids slow activity in the central nervous system. When taken together, the slowing compounds. Breathing becomes dangerously shallow. The risk of respiratory depression and death increases significantly. This warning was issued because reports were accumulating after the drug had already been in widespread use for years. The warning came after the harm was already happening. The label also warns about physical dependence with long-term use and about the danger of stopping suddenly, which can trigger increased seizure activity, even in patients who were not originally prescribed it for seizures. Stopping gabapentin abruptly after months or years of use requires medical supervision and a careful taper. This is information most patients receive only when they try to stop and discover they cannot do so easily. None of this means gabapentin is always the wrong choice. For documented nerve pain, particularly post-herpetic neuralgia, it can provide real and meaningful relief. What it means is that the rapid expansion of its use into dozens of off-label conditions, often for years at a time, has outpaced the evidence for long-term safety in those populations. For cognitive monitoring, research and clinical guidelines now commonly recommend that doctors perform cognitive assessments on patients taking gabapentin long-term for pain, particularly those over 50. Many doctors discuss limiting the duration of gabapentin use where possible, rather than treating it as a permanent solution, and reviewing whether the original indication still justifies continued use. For patients taking gabapentin alongside opioids, sleep aids, or other medications that quiet the nervous system, many pharmacists and doctors recommend a careful review of the combination given the respiratory risk identified in the FDA warning. And the questions worth bringing to the next appointment: what condition was this medication originally prescribed for? And is there still clear evidence it is working for that condition? How long have I been taking this? And has anyone discussed whether that duration is appropriate? Has my memory or thinking changed since I started this medication? Are there other approaches that could reduce or replace this prescription over time? These are not questions that undermine the doctor. They are questions that ensure the treatment still fits the patient, and that the patient understands what they are taking, not just that it was prescribed. Subscribe to MedTruths. Every week we open the label on the most prescribed medications in America, including the ones prescribed for conditions they were never approved to treat. Here is the truth about gabapentin. It was approved to quiet 2 specific conditions in the nervous system, and for those conditions, it can provide real and meaningful relief. It became the 6th most prescribed drug in the country by expanding far beyond those 2 conditions into dozens of off-label uses that were never formally studied with the same rigor. And the mechanism that provides that relief, the same calcium-blocking, signal-dampening action, also affects the brain systems responsible for memory, attention, and cognitive sharpness. Slowly, gradually, in ways that feel like aging, in ways that are easy to attribute to the condition being treated rather than the treatment itself. The cognitive side effects are listed in the FDA label, with specific percentages from clinical trials. The breathing risk warning was issued in 2019, after harm had already accumulated. The research connecting long-term use to cognitive decline was published in 2025. And the conversation in medicine is still ongoing. That information exists. It is in the data. It is in the research. It is in the label. It has always been there. You just needed someone to read it out loud.